know if all of you have met Sir John Oldham. He's the Department of Health lead for quality and innovation. No, productivity.
Yeah, don't forget the PVIT.
Don't forget the PVIT. And he's going to present the social enterprise kite mark of excellence to Bob Palmowski, our chairman.
Very well done. Thank you very much. Thank you. May I just say, on behalf of everybody, I thank you very much, and I've basically really had the opportunity to represent you, and thank you for giving me the privilege of doing this. What I wanted to do is, in just a few words, say that this organisation has been in operation for the past 16 years, since 1994. Yeah. And it's really down to the hard work and the diligence of all the staff in creating what we are at present. We strive to provide a quality service at a cost-effective way, and we perceive ourselves as a beacon of innovation, and I hope that with this award in hand we will be able to expand our services and continue to provide the services. Thank you, Sir John. Thank you. Thank
you. It really gives me enormous pleasure to give that to you for several reasons. One is that you look after my mother. So I'm really pleased that we've got a quality out-of-hours service here. And secondly, as I was saying over lunchtime, that going for these sort of awards is a good discipline for actually shaping yourselves for what is coming in the future. And out-of-hours can tend to have a shaky reputation in various parts of the country. And for you in what is not an overwhelmingly wealthy area to create a beacon of excellence about what an out-of-hours service should be doing, I think is wonderful. And I always take something away in order to be able to talk about people around the country. So you may be assured that I shall be pointing people in your direction if they want to see how an out-of-hours service runs. And delivers good quality, and I hope that you won't regard this as an end point, but is simply a stepping stone on achieving other awards and doing even better things to be. And the challenge I give you: why don't you be the best out-of-hours service in the country in terms of quality and care, and then you can actually take over the others.
I think we are already.
Absolutely. Yeah, I don't think it's
Sounds like a plan.
But as I say, it sort of sets you for the future, and I'd like to just spend a minute, if I may, seeing I'm here, to talk a little bit about that in particular relevance to urgent care. And as you may know, that I am the lead for the work stream for urgent care, and we've been focusing on changing the architecture. And I'd like to use the opportunity of being here today to knock on the head some of the misnomers about what we're doing. Over the past few years, there has been a system in this country which is so fragmented that it would take Einstein to work their way around it. So it's no wonder that a lot of patients default to 999 and A&E. And I would say to people that the concept that you should spend energy and effort in educating patients' quotes about what is urgent or not is a Canute strategy. Because what we should be doing is educating the system to respond rationally to whatever anybody calls urgent, because they will continue to call anything urgent according to their personal circumstances that day, what's going on. So therefore what we need to do is start to make a sense of some of the nonsense. There are we looked at two PCT areas, not hugely away from here, there were 25 different places that a person could go to for urgent care. That some were called the same and doing different, some were doing the same and called different. And what they did on a Tuesday or a Thursday could be different if they had a nurse prescribing or not. Be it walk-in centres, be it whatever name somebody attributed to them. Many not designed in any strategic fashion as to what were the needs of that locality and geography, but simply a knee-jerk reaction to the train that happened to be passing on the policy front that time. So we need to make sense of it because it's duplication, it's inefficient, it's poor care. And hence the reason for giving a single point of entry through the new number 111. The error most people make is assuming that that is replacing, say, people coming to you directly or ringing their practices directly. It is not a substitute for that. Patients will continue to do that. You will continue to have that function. And it's a misnomer and a misunderstanding to suggest that it is other. What it is a mechanism for people to, if they, instead of dialing 999, they're not sure if it's that urgent, they dial 111. What happens is that a person receives that call, a bit like our receptionist if you like, receives that call and uses an evidence-based software such as NHS Pathways, which is about the only thing, I think, that all the Royal Colleges have ever endorsed collectively. And out of that, that is a navigational software. Out of that, it says, well, for your particular problem, it's social services urgency, we'll put you in touch with them. Or you need to go to the minor injury unit. Or you might need some telephone advice. If it's the out-of-hours service that gives telephone advice, we'll put you through to them. And they can do that. Or it may be NHS direct equivalent. Or it may be that you need an out-of-hours visit, so we'll put you through to them, and then you can do more of a clinical assessment. This is not a clinical assessment other than a navigational assessment. It is not substituting for a doctor or a nurse saying, this is what you should try for the next few hours and ring us back. It is not that. It is actually a navigational software to where you should go within your locality, and they know where you should go in your locality because there's constructed a directory of services which says what's on offer. Now, from your geography, what's going to happen is that a majority of places is going to be you for out of hours in these sort of thing. That doesn't change your modus operandi. It simply means that people who would have just turned up at A&E are given alternatives. And that has to be the right thing to do. The third thing we're doing is saying, well, when I looked at these 25 places, I said we must set about creating an evidence-based specification for levels of urgent care. So we've done that with the colleges and the academics and so on, and I've come up with 3 levels of urgent care so that commissioners can commission against that specification. So from 25 we'll have 3, and then we'll be putting some names to what those 3 should be. That's now with the Secretary of State. And I know you want me to tell you what the names are, but I'm not going to.
On camera.
In any way. But the making sense of the system, rationalising it to make it better for patients is what we're about. And then once you start having that specification, you can then start commissioning for quality, which is where we come full circle, the sort of work you've been doing comes in. But I do want to emphasise, because I've seen some of the documentation floating around the Northwest, this is not a replacement, this is a front-ending your stuff. You will be one of a number of navigational options. Sending the community nurses in might be one. Mental health team would be another. Minor injuries unit. There's nothing to stop you, I guess, in this any willing provider world to be running some of those things, if you really want to think. But I do want to reassure you, because the key to this, the key switch, is being able to toggle between 111 and 999. That where this started out in North East, and like any of these things, I don't just rely on PowerPoint. I go and smell the coffee. I actually go to the control room. I listen to the calls. You know, that saved around 1,500 ambulance journeys a month, plus all the knock-ons. And in the times when finances are going to be tricky, we have to work at ways of improving quality, creating efficiency. And having people duplicating services, rolling up an A&E when it's not appropriate, is not a good way for us to look after people. What is a good way for us to look after people is making sure we have a good navigational route to people like you, who can provide the clinical support either by direct visiting or over the telephone, that if people aren't in your sphere, that they are already been triaged someplace else. That's what it's about. So I hope that you will embrace that new architecture, because it is going to be across the country. That the fears that it's replacing what you do or what the practices do is a nonsense. I wouldn't have it that way as a GP. I recognise the organisational memory of my receptionist when somebody rings enables that call to be much more efficient than if it's somebody who doesn't know them. So I recognise that. So there's no way that I would be introducing something that would substitute for them. So I would encourage you to think ahead to the future, to build on what you've done, to continue to offer a good service to all your patients, and not least my mother. Many congratulations. It's been a joy to be with you this lunchtime. Well done indeed.
Thank you.